Welcome to State of Reform's virtual series, 5 Slides We're Discussing, with some of healthcare's most thoughtful leaders. And now, the host of State of Reform, Vern Smith.
Well, hello, everyone. Thank you for joining us for today's 5-slide discussion with State of Reform. And today we're focusing on lessons learned in the early implementation of CalAIM. I am Vernon Smith, one of the hosts here at State of Reform, and I am very excited about the discussion we're about to have today. This hour promises to be a really rich conversation. And I say that partly for this reason. When you look at Medicaid programs across all the states and look at everything that Medicaid programs are doing to make their programs better, it is very clear that what is happening in California right now under the umbrella of CalAIM is one of the very most ambitious, very most significant policy changes and program implementations happening anywhere in the country. And I say that partly because of the scope of the initiative and partly because of its complexity. But of course, you can say that about a lot of things in California just because of its size. But I really say it because CalAIM has such a potential to make an impact on the healthcare delivery system, the payment systems, to improve health and well-being, actually, of all Californians, but starting with some of the most vulnerable Medi-Cal beneficiaries who happen to have complex life situations and high healthcare costs. So I'm really very excited about the discussion today. And I know that those of you who have joined us also have a sense of CalAIM's significance because almost 600 of you have registered for today's discussion. And I mention that because that is a record number for any 5-slide discussion going back for over a decade. So I know this record is because of the topic we're talking about, but it's also because of the great speakers that we have today to discuss their experience with CalAIM implementation. So before we begin, 2 very quick housekeeping items. First, we would like for you to be part of this conversation to the extent that it's possible in this virtual format. So you notice down in the corner of your screen, a chat box where you can ask a question or pose an issue you might like our speakers to say something more about. We love it when you take the time to tell us what's on your mind, and we'll do our best to get your question to our panel speakers. Second, I need to mention that today's 5-slide conversation is sponsored by HealthNet, and we're grateful that HealthNet stepped up with their support so we could have this important conversation today. So today's discussion is being recorded, so you and your colleagues can watch the replay as soon as it's posted on the State of Reform website. So without further ado, I'd like to begin by asking our speakers to introduce themselves. And when they do so, I'd like for them maybe to address 3 things. First of all, if you could introduce yourself, maybe say a brief word about your organization, and tell us one of the topmost issues that you're spending your time on and mental energy on these days. So Martha, let's start with you.
Well, Vern, thank you. And thank you for hosting today's session. We believe it's critically important for us to have these discussions and spread learnings because it's going to take all of us to really transform the healthcare delivery system. So it's just a real pleasure to be here. I am Martha Santana Chin, and I have the privilege of serving as the Medi-Cal president for HealthNet of California. And in my role, I have responsibility for managing the program that cares for 2.3 million individuals across the state. HealthNet has been serving Californians for over 40 years. It's a native California plan, and it's one of the largest and longest serving, most experienced Medi-Cal partners in the state. I'm just very excited to be here because over the last couple decades that I've been working in the healthcare space, I've really dedicated myself to serving underserved communities and working with providers and federally qualified healthcare center systems and hospitals and health plans to really make a meaningful difference. And not in my wildest dreams could I have imagined that I would be in a role that had the opportunity to make such a significant impact in partnership with many of the folks that are on the line today, Kitty and Robert. And so what I'm spending a lot of time on right now is just trying to figure out how to make sure that we focus on improving the operations out of the gate and really get to a place where we're scaling the services, making folks aware of what's available, and delivering on the bold ambitions of the program. So it's no light undertaking here that we have embraced, but very excited about the future. And with that, I'll turn it over to Kitty to introduce herself.
Yeah, Kitty, you're next.
Hi, everyone. I'm Kitty Bailey. I am the CEO of the San Diego Wellness Collaborative. The San Diego Wellness Collaborative is a relatively new nonprofit organization focused on building population health and health equity in San Diego County. We do that through multi-sector initiatives. I'm going to tell you what those are. We have Be There San Diego, focused on heart attack and stroke prevention. We have the San Diego Accountable Community for Health, which is focused on root causes of health inequities and addressing those. And then finally, we have something we've built really as a response to the Health Homes pilot and now ECM and community supports, which is called Neighborhood Networks, and it operates as a social services IPA. I am spending most of my days really building out all those infrastructure pieces that we need as the new ECM vendor and new community supports vendors to really build out a robust response to provide this new set of benefits to the medically vulnerable Medi-Cal population. Thank you.
Yeah, awesome. Thanks, Kitty. Robert.
Yes, my name is Robert Jones. I'm the founder and CEO of Roots Food Group. We also have two nonprofits, Roots Food Foundation and feedingtheblind.org. I'm a California native. My family had farms growing up in the Central Valley. I studied agricultural business at Cal Poly San Luis Obispo. I still guest lecture there and then did executive management education at USC. We make medically tailored meals and a food is medicine product, which is part of the community supports and CalAIM program. And the light bulb came to me in 2015. I signed an exclusive licensing agreement with the American Diabetes Association, and the concept of food is medicine, although as a farmer all the way back, of how eating the right food can make a difference. And we'll get into kind of the slides later, but food is such a core of health equity or health inequities, right? Based on how much you can afford to eat and not. We're spending a lot of time scaling programs. Part of California, the infrastructure side of it and the meal production, as well as some of our other national programs as well. So pleasure to be here today and excited to talk to some of the leaders in the space and the interested parties and questions that'll come out of the discussion.
Well, thank you, Robert and Kitty and Martha. A great start for us today, and thank you for joining us for today's discussion about the lessons we've learned in the early implementation of CalAIM. So, tradition has it that the host gets to start with the first slide. So, my slide is designed to kind of give an overview of CalAIM, its objectives, requirements for managed care plans, who are implementing it and what they, what the requirements they have to meet. So in my 2 minutes, here's a very brief introduction, a description of this very busy slide, which I have to say right off the bat was prepared by the Department of Healthcare Services and used in one of their presentations earlier this year. So first of all, just by way of background, CalAIM is the acronym, as you all would know, for California Advancing and Improving Medi-Cal. Any of us who have worked in Medicaid over the years, we're always focusing on how to make the program better. And we know how hard it is to actually achieve transformational change. But with CalAIM, what we see here is an initiative where the goals are extraordinarily ambitious. Back in the day when I was a Medicaid director, I used to say to my staff, incremental goals challenge no one. Well, with CalAIM, the goals are anything but incremental. They are significant, they're bold, and there are many challenges here. So CalAIM is comprehensive, complex transformation. It seeks to fundamentally change Medi-Cal by addressing physical health, behavioral health, long-term care, developmental issues, dental care, the whole package of things that make us healthy. So, when all of this works, we expect to have, better health care, better health outcomes, better quality of life for those who are served. So one of the key focuses of CalAIM is population health and specifically addressing the social determinants of health. And so that gets us to this slide, which focuses on enhanced care management, or ECM, and community supports. So ECM is person-centered care management, enhanced care management for the highest need Medi-Cal enrollees. ECM is designed to make sure that enrollees get exactly the care they need, exactly the right time, the services they need in their homes or wherever they get their care. Community supports are non-medical services like housing or medically tailored meals that Robert will be talking about more a little bit later. These services go directly to the social determinants that we now know are so important to health status, longevity, quality of life. We actually now have data, studies that show that these services are just as important, if not more important, than the medical care delivered in medical settings. In fact, they're sometimes referred to as in lieu of services because they do reduce the need for traditional and usually more costly medical care in hospitals or doctors' offices or skilled nursing facilities. So it's the managed care plans, MCPs in this slide, that deliver or arrange for the delivery of community supports in ECM. And it's all delivered through a model of care, or MOC, the acronym in this slide. So this slide lists the terms and conditions for managed care plans on the left column. And in the right column are the key requirements that the managed care plans must spell out in detail, like the populations to be served, the community supports to be provided, how the populations will be engaged, data reporting, and much more. It's all very complex. It's a lot of work. It's definitely challenging, but truly it has the potential to improve lives. And that's the whole point of all of this. So that's my introduction with my slides. So with that, Martha, let's turn to you. I understand you brought 2 slides today, so tell us about them.
Yes, thank you, Vern. And I understand I get a little more time because I do have 2 slides, but I am very excited to talk about CalAIM today. Since, HealthNet really has very eagerly contributed to this program's groundbreaking development. Alongside our community partners like, Robert and Kitty, we've really done quite a bit of work to get the first phase of the CalAIM program implemented across our footprint throughout the state, with the goal of really strengthening our safety net and getting to a place where we're driving improved equity, health equity. So for decades, HealthNet has been partnering with the state to transform the Medi-Cal delivery system from the inside out. And as the state continues to envision the future of Medi-Cal through CalAIM, I'd like to just take a moment on behalf of HealthNet to really commend the state, DHCS in particular, on this historic program and the success so far. We view CalAIM as a very unique opportunity to closely collaborate with county agencies, community-based organizations, the broad healthcare ecosystem to help drive big programmatic changes, much like the ones that you've described. And this is all in the spirit of trying to just make sure we're making an impact in the communities and the counties where we live and where we serve. So CalAIM and community supports, as you know, first of all, California's incredible diversity is very much reflected and magnified in the Medi-Cal population. And a unique aspect of that CalAIM program is this community supports services. And it's really important because as we know that many of the individuals that are being served by the Medi-Cal program today have a higher degree of disparity simply because they have higher social risk factors. And so because of those higher rate of disparities, it's important that we have tools available at our disposal to address their needs squarely and at the root cause. And by doing that, we will be able to drive improved health outcomes, advance health equity, and do the right thing in terms of being good stewards of the healthcare dollar, because we will be able to avoid costly and unnecessary settings of care. So at this point, HealthNet has implemented community supports across all 31 counties in which we operate. And we've leveraged our statewide relationships and long-term trusted partners and providers to facilitate that transition. We've also leveraged extensive experience that we've developed over the years in serving the Medi-Cal program. We have the privilege of being able to serve a wide array of individuals, everyone from, moms and children to youth in foster care to persons with disabilities, and the list goes on. And so you can imagine, as a result of being able to serve those diverse populations, we've developed expertise over the past few decades that have been really important to positioning us for where we are today with the CalAIM implementation. And so that extensive experience has really helped us to frame our CalAIM implementation around 4 main pillars, and that's health equity, local engagement, investments, and community input. HealthNet has made health equity a priority for the past few decades. And as a result, we've developed structures and processes to support equity, such as using and collecting race, ethnicity, language, and other equity indicators to make sure that our programming is addressing the needs of the people that we're serving. We also made it a point to hire from within the communities that we serve to ensure that our teams reflect the communities that we serve and that we're better connected with the people that need our support. We've also made cultural competency and implicit bias trainings a requirement, not only for our staff, but also for our provider network, to really make sure we're driving consistency and support, addressing disparities and advancing health equities throughout the system. Next, our unique history of local engagement has also been a paramount building block here. We know that health equity starts at the community level and is best delivered locally. So we've partnered with local organizations to build a robust and responsive provider network that integrates non-traditional Medi-Cal providers into the state's Medi-Cal safety net. And as part of that, we've made investments very strategically. In fact, we've invested over $100 million in 500 community-based organizations. And these investments over the years have really allowed those organizations to pilot and advance promising ideas that are now really the foundation of community supports and or sustaining critical services and resources that are necessary to wrap around the needs of our members. We've leaned into our community partnerships quite heavily. Actually, we've constantly look to get feedback and input from our trusted providers in the communities to really make sure that we are informing our programming with the voices of, our providers and our members as a result. And so, these partners have track records that of serving the needs of Californians in that way. And so it's just been a true gem and resource for us to be able to lean on them. Now, if you go to the next slide for me here, please. So want to just talk a little bit about lessons learned and our work in action. So it's the 8-month mark of the CalAIM program, and it's still very, very early on. Before the call started, Kitty and Robert and I were just reflecting on just the state of affairs. And I'll say we're optimistic, and we know that it's a massive undertaking, and there's quite a bit of work to do to really get to the full promise, realize the full promise, but we have a good start. And we've reflected on the first 8 months of the implementation and identified a number of lessons learned, best practices, et cetera. In fact, there's a report out there that, Vern, I'm happy to send to you so we can share with the viewers today. But we wanted to also call out 3 very important recommendations. First, extensive collaboration with plan partners and providers is just paramount. I'll go into a little more detail on what I mean by each of these, but wanted just to hit on those highlights first. There is a foundational need for operational support and funding for local providers. And lastly, the need for data and timely data is critically important and essential to informing solid program design. So first, when we think about the collaboration, at the direction of DHCS, HealthNet and our plan partners collaborated in an unprecedented manner. And our focus and our goal was really to minimize burden on our providers, our county partners, and others. So we really made that a priority to work hand in hand with our plan partners and local providers to make sure that we're delivering on just that and deepening our knowledge of the community to make sure that we get it as right as we can from the beginning. This collaboration is so important because county-specific nuances you can't underestimate in how we're approaching our work. And it's been critical to making sure that we're delivering culturally responsive care. And that is absolutely a key to reducing disparities and advancing health equities for this Medi-Cal population. One of the things that I'm very proud of and I wanted to be able to share is that this unprecedented level of collaboration resulted in actually standardized processes early on. Things like, getting the application process, certification application process combined. And so there was one process across plans to really support providers as an example, trainings and resources that we've developed, we've done that jointly. We are now running CalAIM roundtables in each of the counties in which we operate, and it's not a plan-specific roundtable, it's a community-specific roundtable. And so thanks to the work with our partners, including the managed care plans, we've made some impact there. Next, it's really the foundational need for operational support and funding of local providers. By design, we brought in many community supports providers into our network that had never really worked with managed care plans. And that meant that not only did we have to develop infrastructure, but they also had to develop infrastructure. And so it's really critically important that we support them in their needs to build capacity and train and develop their own workforces. So one of the things that we really recommend is that we continue to invest in workforce development, training, and recruitment to build that capacity that's necessary, and that we invest in technology to reduce administrative burden, standardize, really drive efficiency so that our providers can really focus on caring for the needs of our members instead of having to deal with administrative hassles. In fact, in April, in collaboration with our managed care plan partners, HealthNet released a request for applications related to incentive program funding. And this funding was really intended to complement and expand enhanced care management and community supports capacity in a variety of ways, including training, workflow design, technical assistance, building capacity, and the list goes on. Some of the activities that were funded through that, as an example, are giving providers access to care management platforms, billing systems, closed loop referral systems, health information exchanges, reporting capability, and the list goes on. And then lastly, the essential role of timely and complete data sharing. Accurate data really allowed HealthNet to more intimately understand community supports need at a local level. And these insights and the information that we were able to gather really helped to inform the way that we were implementing the community supports services. Not only in terms of the service suite and the timing of when we rolled out services, but also who might the providers be that could best serve the needs of our population based on who our members are and what their needs are specifically. And so with that, we really do recommend that we integrate various data sets to capture a more holistic perspective of community needs to effectively tailor our provider networks and then meet the county specific and community specific needs. So just in closing, I'll just say, HealthNet is on track to implement the next phase of CalAIM reforms, and we're very excited about that. And as this work continues through 2027, we're committed to leveraging our expertise from the past, learnings of today to make it better for tomorrow, and look forward to working hand in hand with our managed care partners, provider organizations to make sure that this program is really successful. And I will say, despite all the good planning that we all did, the state, the plans, our provider community, the collaboration, CalAIM is a massive and complex initiative, and there are challenges. And so I think to really address those challenges, it's going to be really important that we continue to be proactive, collaborative, and creative in our approaches. And we're just, again, very, very optimistic, very excited, very committed to the program. And we look forward to deepening our partnerships to drive progress and working with many of you. So thank you.
Yeah, thank you, Martha. That is just super great, 2 great slides. So thank you very much. Before we move on to Kitty, I'm just really struck. You've done a lot of work with the community and with providers and so on. What about inside the health plan? Would you be able to say anything about any changes you had to make internally to support, to add to your support of community support providers?
Absolutely. I mean, this was a massive culture change within the plan as well. Many of the people that work for the health plan have been working in a health plan for many, many years and had not had exposure to how community-based organizations operate. And so simple things like the idea that a claim must be submitted to capture a service in a way that is consistent with claims practices, that infrastructure and that capacity and that support did not exist externally, we had to get creative about how we were going to support accepting invoices as an example. And so that required not only that our people understood how the outside world operates, but that also our IT systems and our platforms get modernized to be able to ingest data in ways that we historically had not, to really do a good job of supporting the provider community. And there's a lot more work to do. There's a lot of learning that happens every day. We are leveraging insights, not only from our community-based organizations, our county partners, but also the foundations. I will say the California Healthcare Foundation in particular has been phenomenal at putting out primers and things of that nature that have been very helpful to our teams and our staff to inform their thinking.
Yeah. Oh, thank you. That's great. You talk about receiving invoices. There might be some issues about preparing invoices as well that maybe Kitty and Robert will talk about. But let's move on to Kitty and hear what you have to say with your slide, Kitty.
Sure. Thank you. Well, one, I'm just really grateful to have the opportunity to talk about what we have been learning the last 9 months from our unique perspective as a social IPA, where we are really trying to leverage the strengths of community-based organizations in San Diego County and deliver those enhanced care management and community supports benefits at the grassroots level. So not only are counties unique, but there are so many neighborhoods and communities within the counties that require their own unique approaches. And we feel like that's one of the things we're able to do by having a network of community-based organizations who deploy ECM lead case managers, and we're also deploying housing navigators at this point. I too, like Martha, I've been working in Medicaid programs for a long time, almost my entire career. And if I never thought we would get to a point where we'd be able to say, I can pay for your housing deposit. And so I don't think we've actually done that yet, but we're getting very close. And that's one of the visions of CalAIM, is those are the kinds of supports that our vulnerable clients can receive to ensure they have that housing stability, to ensure that they can get their medical needs met. And so I think this is an amazing vision. We all are completely dedicated to the transformation of our healthcare system into a wellness system that goes beyond sick care for this population. And we're all in it together. And so I really just want to acknowledge, I have had hours of phone calls with all of the Medi-Cal MCOs, including HealthNet, amazing partnerships. Everybody's very dedicated and working very hard. Community-based organizations. I know the Department of Healthcare Services. I know the Medi-Cal MCO, the staff, all the people that work there have been working incredibly hard to make this happen. And so it is just a really heavy lift. So before I get into some of the areas where we're still having challenges, I want to just acknowledge how hard everyone is working. And so with that, I do want to say, yes, as someone who is here trying to figure out how to build this infrastructure from the ground up, starting on January 1st of this year, there are significant implementation challenges. It is important to remember that these are really, in a lot of ways, new partnerships. While many of our CBOs partners had community engagement or community benefit type relationships with the health plans, they didn't have contractual and business relationships. And so those are really new ways of working together. And we just have to recognize that new ways of working together take time. Here in San Diego County, we have so many assets and strengths that we are bringing, and we still are having challenges. So we have Healthy San Diego. We have the Community Information Exchange. We have the county that's highly engaged in this project. We have really sophisticated, strong community-based organizations who have been working in their communities for decades. We were both a health homes pilot county and a whole person care pilot county. And with all of those strengths and assets, we still have extraordinary implementation challenges in terms of creating a system approach. And those include, data sharing for clients and whether or not that's referrals, consenting, engaging, and enrolling clients just to begin with. That's important, and we are still working on building that out. In addition, we also need data at a systems level, at an organizational level, to help us make better decisions on a program level for the entire county of San Diego. So I'm talking about kind of data I'm talking about are things like, how many folks do we think in San Diego County and other counties are eligible for ECM, are eligible for the various community supports? How do we build out the right workforce for that level of services? How are we doing on enrollment as a whole for our county as a network of partners coming together and really looking at this through a lens of community collaboration, knowing that we can only achieve our shared goals together? And we need those county-wide insights, especially in a county like San Diego, where some of that business intelligence is divvied up among several different plans. Where do we have a repository where all that information lives so we can make smart decisions? We recognize that important investments are coming in to build capacity, whether it's the IPP dollars or the PATH dollars. Those are going to be super important, and we're excited about those. But we also just need to recognize that relationship building takes time, trust, and mutuality. And when I say mutuality, what I'm really trying to get at is that the CBOs, who are the ones doing the feet on the street work of getting these clients engaged, we have important unique perspectives to contribute to the success of the program. And we really need ways to figure out how to integrate the learnings that are happening on the ground in order to build towards our vision of health equity. We need to be working together, asking good questions, being curious, being willing to learn from each other, and being willing to make changes to the program. That's the way this is going to be successful. So if it's program requirements, program rates, Those are the kinds of things we have to be willing to look at together. We know in San Diego County that enrollment has not reached the original DHCS projections. I think this actually might be true statewide as well. That means also that community supports utilization is low. I'm looking forward to having the conversations around why is this happening? What can we do to improve it? What could we change in terms of infrastructure, program requirements, rates to actually remedy some of the barriers we're seeing today and actually get that impact we all want to have? So with that, I just want to say, I know myself and other CBOs, we consider this an opportunity of great learning and great future hope. And we want to really come together and be curious together and form a learning laboratory, really learn from this first 9 months and make the changes that are needed to move us forward with the full realization of this amazing program for the Medi-Cal clients who are vulnerable and need these services. Thank you.
All right. Yeah. Thank you, Kitty. That was great. We're getting some good questions coming in on the chat. So thank you for all of you out there for that. But Kitty, I understand the San Diego Wellness Collaborative has developed kind of a network of community-based organizations, kind of a social IPA. Is there anything more you can tell us about that and some of the implementation challenges that you've faced? And, are there some lessons learned or can it work for others?
Well, one of the first things I want to say is I really want to appreciate that the managed care organizations in San Diego County, including HealthNet, have been very supportive of our social IPA. They've allowed us to do subcontracts through all of our ECM and CS contracts. So that's a really important learning right there, that subcontracts in these contracts allow for network approaches. I know that our partners who are part of our network appreciate not having to all learn how to do Medi-Cal billing, for example. Now all have to create new privacy and security, HIPAA trainings. They get to do all that through our shared network. So I just think the shared network approach is something that is very promising and could really be leveraged across the state to build out capacity and make it just as easy as possible to engage as many clients as possible.
Yeah, great. We got some other questions here, but let's go on and hear from Robert. Tell us about your slide.
Great, thank you. Just in starting, Vern, with you and Martha and Kitty, I just want to reiterate, this whole thing is a challenge. I mean, that's why it's everyone coming together. We call it the village, right? Because it's really taking the strengths and turning weaknesses into strengths, from the various parties involved that typically just don't get together. And that's how it was constructed. Martha, you mentioned it's a challenge, and it is an absolute direct challenge. And I think we're all up for the challenge itself. And Kitty, you're talking about the lift, and we're all lifting, and all boats rise in this tide, when we all have a common mission and goal. So I think all those things they're difficult, but that's also the opportunity that California has really been very proactive, within the nation to be one of the first ones to actually look at the equities and how you change the infrastructure of healthcare and food and provider networks and community support. So I just want to reiterate all the same that we see the same thing, and we appreciate the opportunity to make real change and significant change for the state of California. So my company makes and distributes medically tailored meals. And the numbers are kind of off the charts. And these are some of the numbers that are in the slide today of the benefits of eating the right food and how that really relates to the cost, the health equity, and all of those things that go with it, the cost of healthcare. And when you see a 32% reduction in net healthcare costs that was derived from the Department of California Health Services pilot program for medically tailored meals, that's a significant number when you're actually changing somebody's health at the same time there's a massive return on investment because you're lowering the cost of healthcare. And where can those dollars be better served or reapportioned, right? That's against $128 billion annual budget for the state. I mean, that's a $40 billion number of real change and redistribution of those dollars to better things. You know, to one side of my mouth, I can say food is medicine. And the other side of my mouth, I can say food is poison. And cheap food has created a very expensive problem, which is the cost of healthcare. So many of the chronic diseases are really foodborne, and they make up substantially, 80-90% of the total cost of healthcare. I mean, you're talking about on a national basis, it's $4.2 trillion a year. And if you eat the right foods, you can actually put into remission type 2 diabetes, and it happens very quickly. The body's very resilient, whether you're a child or an adult, that you start eating the right foods and you get healthy very quickly. Just like if you break your leg at 12 years old or 40 years old, it heals very quickly. So when you start filling your body with the right nourishing food, it really makes a substantial difference. When you look at some of the other elements of a 63% reduction in readmissions to the hospital, or a 50% increase in medication adherence, or a 97% food security versus insecurity, all those were elements and outcomes based upon the 3-year pilot program that the department did relative to medically tailored meals. So it's groundbreaking for sure. California is well ahead of the rest of the pack. For the first time in 50 years, they're having the White House Hunger, Nutrition, and Health Conference, and they're just starting to talk about it, right? California has already implemented it. I mean, even though they're talking about it today, we know how long this has taken. 3 years of pilots and implementation, and you try to do it on a federal basis, it takes years and years to get it done. But the groundbreaking of 2 meals a day, 7 days a week for 12 weeks is a single prescription, basically, of the medically tailored meals for chronic disease and conditions. Macro number basis, Kitty, you said, who's eligible for this? Just on the chronic disease basis, you're talking 60 to 70% of the population. That's just a standard number. So as it relates to just that one service of medically tailored meals, 60 to 70% of the Medicaid population in California would qualify for that, not including all the other services. So when you look at how pronounced this is and the lift and the scale and the need for growth from all levels of the organization, it's going to take the entire village. So one of the things that, because it's so groundbreaking, a lot of people don't know about this. So we're doing our own grassroots outreach at the community level, at the county level, at the provider level, with our complementing ECMs and managed care plans, right? Because those are all the elements of the village that can have a louder voice and touch more people when we're really exposing them to the services that are in such need. So we're just really excited to be part of this, ready, willing, and able for the challenge and the lift and all the above. If we hold hands, lock arms, and get through it together, I think it's going to be a huge success for the village involved, for the population, for the state of California, to get healthy. We have a very sick society today. You're talking 60 to 70% of the population is unhealthy physically. I mean, we have to change that. And I think CalAIM is well ahead of the pack and addressing the problem with these new services, The approach is different. And I can't be more happy to be on the panel today and doing our part as a provider within the space.
Yeah, thank you, Robert. I mean, the slide that you've got has some amazing statistics on it. I don't know if there's anything more that you can say about, the increase in Medicaid adherence, or the likelihood of being discharged home, or reduction in hospitalizations, all of those things. I mean, these are dramatic statistics. Why has it taken so long for all of this to be recognized?
So, I mean, it's a simple question. It's a simple answer. Fee for services. I mean, no one got paid for anything. This is changing, addressing the problem through preventative, value-based care, proactive care. Healthcare stopped at the door, right? You either broke your leg and you had to go to the emergency room, and that was it. But past the door on a fee-for-service model, it's very difficult to address some of these social and cultural and geographic inequities. And that's changing. And I think that secular shift happened, 3-4 years ago, where it really started gaining momentum. And now you're seeing healthcare embrace food when "let food be thy medicine" is 3,000 years old, right? This is nothing new. It goes all the way back to before there was healthcare, right? It started with herbs and food and ointments and the natural parts of the holistic parts of healthcare that really make lasting change if you can stay on it.
Yeah. Yeah, so that's great. So, Martha, I'd actually like to kind of turn to you just for a second and see if you have any thoughts about, what Robert has shared with us, and Kitty as well, in terms of working with these community-based organizations and the services they provide.
I think what I would just say is, I think Kitty and Robert identified several things that, it's still a work in progress, right? There's a lot that we yet have to do. I loved Kitty's comments about looking at this as a community, like that community lens. How many people have we enrolled in the program? How many people have we supported? How many people have we given that ladder to get closer to getting to equity together, right? We still have a lot of work to do there, I think, collaboratively or together with the other health plans and with our community-based organizations and county partners. We will get there. It's going to take a little bit of time before we're able to really make very good use of all the data that's available. But we're having the discussions around building the foundation. I'll give you a couple of examples. On the data side, we are having discussions around how do we integrate health information exchanges, community health information exchanges, housing management information system data into the way that we risk stratify and target and identify members. And then how do we make that information available to all of our providers across the ecosystem? The discussions are happening. One of the things that I mentioned very, very briefly was that we are hosting a series of CalAIM roundtables. And when I say we, it's not just HealthNet, it's all the health plans together. And this is happening up and down the state. These are the topics that are getting discussed together. And one of the things that really does allow for is for us to build the foundation at a community level, not a plan specific level, not a provider specific level, not a one-on-one relationship between a provider and a plan, but community. And so it will take time, but we will get there. I am convinced of that. And it actually, there's a question that came up in the chat that I'm going to take the opportunity to answer, if that's okay with you.
Oh, no, please do.
Okay, so Brooke was asking about how community supports may end up supporting individuals not necessarily enrolled in enhanced care management. And Robert talked about this a little bit. I think the way that we think about it, well, I know the way that we think about it is that there really should be no wrong door, right? The family, the member, their provider, others around that individual have an ability to go ahead and refer individuals that may qualify for service. And all of those referrals, all of the plans will take and assess and adjudicate appropriately, and make sure people get connected with services when they need it. So the data that I'm talking about is going to be just another layer to help us identify people early on. But that system and that roundtable, if you are a community-based organization or a county agency and you're not already involved in CalAIM roundtables, I would encourage you to reach out to your health plan partners and liaisons and get connected, because a lot of these discussions are happening there.
Yeah, great. Yeah, I'm glad you took a look at Brooke's question there. And we've got some others which maybe we can get to. Kitty, maybe you've got some thoughts on this subject as well, but one of the things I just wanted to follow up on, these community-based organizations are not traditional healthcare organizations. They haven't had contracts with Medi-Cal before, and it's different, it's hard. And, maybe you can talk a little bit about what do you have to do to have a contract with Medi-Cal and be successful in it?
So I think, one of the things that I think is happening is that for providers, ECM vendors, and community support vendors who haven't had a history of taking contracts from Medi-Cal and are finding themselves now interested in adding this line of business to their organization because it's such a good fit with their skill set. So whether it's a housing organization, an organization that works on food security, there are an amazing amount of resources that are starting to emerge. And that includes the IPP dollars. It includes the PATH application that's currently open. And if those words don't make sense, you can feel free to call your friendly managed care organization rep, and even if it's the community benefit person, and talk to them, because those resources are meant to support community-based organizations. And there are, initial considerations of readiness that organizations and CBOs need to be thinking about in terms of their ability to comply with privacy and security requirements that the health plans have. Those are a pretty heavy lift. To be able to comply with the claims requirements in terms of using medical claims and billing out medical claims, those are important. And then really thinking about, how does this new workforce fit in to your current business model? All nonprofits have business models, so I'll just call it that, whether or not it's an ECM lead case manager, or it's a housing navigator, or somebody doing the asthma remediation or delivering meals. How does this fit in? How does it fit with your mission? Making sure you're having those conversations with your board of directors and having them understand that healthcare, while not traditionally a place where you've done revenue generating contracts, can be an opportunity, and that you are already serving these clients. And I think that's the key here, is we know our Medi-Cal members are already showing up at the CBOs and they are getting services. This is an opportunity now to actually get a contract to reimburse you for some of those services. So I think those are all really important parts of the conversation that CBOs need to be having.
Yeah, great. Robert, do you want to add anything to that?
Yeah, we're probably the outlier in all of this. I'm a farmer, right? I'm a food guy. I built, direct to the consumer food programs for large companies, but our passion is, and exclusively now, food is medicine and medically tailored meals. It's we see things from a different lens because we're not from the healthcare arena. So that's good and difficult at the same time, because we look at things differently. But yeah, it's a lift for sure. I mean, all of our systems have to be HIPAA compliant, and whether it's Medicaid or private insurance or self-insured, right? There's a lift just on the systems alone.
So
universal healthcare.
we have a question about this, but what you've said just raises this issue very clearly. So is there technical assistance available that you would be able to mention here? Any of you?
Yeah, I'll take that. So, first of all, I would like to just hats off to the Department of Healthcare Services, because they do put a lot of information out on their sites. They've had many informative sessions, stakeholder groups, et cetera, et cetera. So PATH, P-A-T-H, Kitty mentioned, and then the CalAIM Incentive Payment Program. One of the very wise things that the state did as they were launching this very hefty initiative is they coupled it with incentive program dollars that health plans are able to earn if we drive the right outcomes. But the design of the outcomes are such that we have to invest in the community in order to do it, right? And so it was a very smart strategic move on the part of the department. And so the first thing I would encourage you all to do is Google PATH, Google CalAIM IPP, Incentive Payment Program. And then, yes, absolutely reach out to your managed care plan partners, because, one of the things that, quite frankly, we were surprised by is we ran in April a round of grant applications, and we didn't get as much uptake as we thought we were going to get. And so most health plans, what we're doing now is trying to figure out, okay, how do we make sure that we get at the next round? But that funding from PATH and from the CalAIM Incentive Payment Program is really intended to help with technical assistance, with systems, with workforce development, training, et cetera, et cetera. So there is absolutely opportunity to get supported on that front.
Yeah, excellent. We are really approaching the very end of our hour here, so we're going to need to wrap this up. So, any last word that you'd like to say? In just a few seconds. Any last thing to wrap it up here before we bring our discussion today to a close?
Go California.
Yeah.
There you go. All right.
I would just say, I can't underestimate the power of this program and underemphasize how excited we are. I mean, we are just very excited about the promise of the program. We think it's the absolute right thing to do. It is a heavy lift. There has been decades of underinvestment in our social service infrastructure. And now in a very short period of time, remember, 5-year waiver, we got to make it work. We got to showcase that there is impact here, and it's going to take all of us. I think Robert said, locking arms. Wholeheartedly agree with that statement. And so, we're looking to continue to partner with everyone.
Yeah, great. And Kitty, last word?
No, I just appreciate having the opportunity to come today. Thank you.
Yeah, that's great. Well, there's so much more that we could say. As everyone has mentioned, this is such a complex, difficult challenge to do everything that can be done, take advantage of all the potential that's there under CalAIM. I should just say, by way of closing, the State Reform Conference in Los Angeles is coming up on September 22nd. There is an entire track on implementation of CalAIM, an update from Medi-Cal itself, sessions on social determinants, on housing insecurity, and food, and bringing community-based organizations into healthcare through CalAIM, and one session specifically on CalAIM implementation. So if there's more that you would like to learn, some fantastic speakers at that conference coming up as well. So with that, let me thank our speakers in particular. This has been such a rich conversation. Thank you so much for joining us today. And all 600 of you who are in our audience today, thank you for joining us as well. Best wishes from State Reform.
Thank you.
Thank you.